This presentation was recorded at the 12th International Conference on Rapid Response Systems and Medical Emergency Teams.
So I was given the title Paediatric Minimum Dataset, and initially I thought, well, that's a riveting title, or that's going to attract a crowd, but nevertheless I've really enjoyed approaching this. In the end, we all have been talking about, are we making a difference? And that's indeed what we wish to know. So what I'm planning to do here is just talk a little bit about the outcomes that we're measuring in paediatrics, and then at the end talk about what we could do here in Australia and New Zealand in terms of fields of data we could collect to make a minimum data set. I've used this slide previously in terms of one of the worksheets that arose out of the ISRRS C215 work. And I show this not because I want you to read all the paediatric studies here, but just to highlight the different ways we report our outcomes. And we are often actually doing different things. So when you look here, cardiac arrest outside ICU, you'll see events per 1,000 days, events per 1,000 non-ICU patient days, admissions, discharge. Similarly, there's different denominators when we look at hospital mortality. And then codes outside ICU generally may include cardiac arrest, and actually very few papers in paediatrics do report on respiratory arrest. So as we know, cardiac arrest outside ICU in paediatrics is really quite a rare event, as catastrophic as it is. Mortality, similarly, unexpected mortality is quite rare. The different ways that's been defined in the paediatric literature to date when reporting outcomes, some will report overall hospital mortality, some will report unexpected deaths, those that did not have a do not resuscitation order, or those ICU mortality of MET transfers to ICU. As we know in paediatrics, though, the more frequent events are some sort of respiratory deterioration. This may be a respiratory arrest or respiratory compromise. Respiratory arrest can indeed even be difficult to define, because when is it an apnea, when is it an arrest? Whereas most people have opted for a definition that takes into account the functional intervention that will occur with the event. Some have defined respiratory arrest or compromise as those children who need intubating during the MET call. Others have also included the bag mask ventilation or some form of assisted ventilation. The other common measure that we use in our paediatric MET studies is ICU admission. The difficulties with ICU admission, though, is indeed this is a process measure. And sometimes it's difficult to interpret what it means, because we know the transfer of a child to ICU may indeed prevent the respiratory or the cardiac arrest, so it's actually a good thing. The other thing is sometimes it depends on organisational issues or even individual staff on any one day as to which child might get to ICU, as well as bed availability. What denominator? So in the paediatric studies that I've looked at to date, as I alluded to before, we all use a slightly different denominator: admissions, discharges, patient days, or non-ICU patient days. So I just want to turn now to looking at some other metrics that's evident in the paediatric literature. And firstly, one that we've used at our hospital and have since we started collecting this data around critical events in 2007. And we actually decide to, all children who have a MET call, we also look at what we call critical events or significant MET events as well. Now, these are defined, as you can see on the left, cardiac arrest, if a child got intubated on the ward, if a child required Narcan during the MET call or a reversal of sedation, if they got an excess of 40 mL per kilo fluid resuscitation, and you can see the other events there. And when we just looked at our first 225 MET calls, 1 in 7 MET calls were associated with a critical event, and children who had a critical event had a 5-fold increase in hospital mortality and were more likely to be post-operative. So we chose these measures because they may, some may reflect delayed recognition of deterioration, but also they were also associated with harm, and they really came out of the trigger type methodology, trigger tool methodology, that's sometimes used in adverse event literature. Another interesting measure of critical deterioration has been work published by Chris Bonafide, who's here at this meeting as well. And they validated a measure to try and look more broadly at what might represent critical deterioration, and they chose to focus on patients who got transferred to ICU and received non-invasive ventilation, intubation or a vasopressor infusion within 12 hours of admission. They were able to demonstrate also that it was much more common to have these events rather than cardiac arrest, and also the increased risk of death. They since evaluated that with their rapid response system and implementation and were able to show a decreasing trend. Another interesting measure is from Patrick Brady, who's also here at this meeting. So I'm very thankful for these colleagues and their data. And this was an interesting study looking at a quality improvement intervention to try and reduce the unsafe transfers. And they defined their sort of critical deterioration metric as a patient transferred from the floor to the ICU, was intubated or received inotropes or greater than 3 fluid boluses within 1 hour transfer or before transfer. So this was much narrower time compared to the previous study where I talked about within 12 hours. Another study that many of us in the paediatric world are waiting to hear is the evaluation, the cluster randomised trial of the implementation of bedside pews. And I think we'll be hearing about this data fairly soon from Chris Pisharam. And he's published, I'm not sure if the reference is sort of muddled in the bottom there, last year in trials and all their outcomes and methodologies for the study. And they also are reporting what they call significant clinical deterioration. And they define that as provision of significant pre-specified respiratory or circulatory therapies, or CPR, in 12 hours before transfer. So now we're going 12 hours before I showed you 12 hours after. They're also looking at those same events happening within the first hour of admission to ICU. So ideally what we want to do is to be able to compare data within our hospitals just in this region or really around the world. We all have data collection, I think the majority of us would have similar data collection forms, yet they're all slightly different. This is just the data collection form from our hospital, and they're all fairly similar in that we ask about various things pre-MET, what happened during the intervention, during the MET call, what triggered the MET call, and the various outcomes afterwards. Wouldn't it be good if we could just actually agree and come up with some standardised measures in collecting data? Here I've pulled out, this is readily accessible from, if you go to the AHA Get With The Guidelines website, and this is a great data set where they are able to, they collect data from many, many hospitals, hundreds of hospitals across the US. And they have the standard MET form, and they have other standard forms too that are readily accessible, as I said. What was interesting in here, some of the pre-MET metrics that I haven't seen reported very often in the paediatric literature was the patient discharged from ICU within 24 hours prior to the MET call? Was the patient discharged from a PACU within 24 hours prior to the MET call? Or was the patient in ED within 24 hours prior to the MET call? They have recently, the paediatric group have published outcomes from this large data set, and it just shows the value if we actually have standardised measures, and then we can get a much better understanding of what's happening in our paediatric world. And so this paper that came out earlier this year reporting the outcomes from 150 US hospitals that reported paediatric data. And what I found particularly interesting was that 40% of the MET events occurred within 24 hours of transfer to the ward from the 3 places that I just mentioned before. So this in itself is interesting, and it might tell us, you know, something about who should be, what sort of level of observation or monitoring these children should get, or does it also tell us about some of the children that perhaps should have gone to ICU earlier and was not recognised. So great, big data sets enable good work. What can we do here? Well, we have the ANZICS, the Australian New Zealand Paediatric Intensive Care Registry, as part of our ANZICS core data. And in that registry, there's 7 paediatric intensive care hospitals in Australia and New Zealand that have PICUs, and then there's approximately another 20 hospitals that report paediatric data from children less than 16 years. There's various fields in that registry, and when I had a look at that, there's a field that talks about ICU admission source. It would be very easy for us to add via MET or whatever the relevant team is that we use at our hospital. There's a small section within that database that focuses on a little bit of data about the recognition and response to deterioration, where they essentially sort of asked for data that occurred over the year. And what was reported there was the number of MET calls, the number of hospital deaths that were non-NFR deaths, and I think separately, when they're referring to hospital mortality, they refer to hospital separations as the denominator. So we already have a little bit of data there. I think what we could easily do and get agreement on fairly quickly, I think, is coming up with an agreed definition for the two key events that are important in paediatrics. Now, I think we often use these definitions in our own hospitals, but I've just taken these from the Get With The Guidelines group and looking at their definitions. Cardiac arrest, so that's anyone who doesn't have a pulse or has a pulse with inadequate perfusion and gets chest compressions, or defibrillation for VF or VT. So that's basically, instead of saying, oh, was this short period of chest compressions, hypotensive bradycardia, is that a cardiac arrest? We have a functional definition. If we do chest compressions, they're in. They define acute respiratory compromise, similarly in a functional way, absent agonal or inadequate respirations that require emergency assisted ventilation. This includes bag mask ventilation, CPAP and the like, as well as intubation. So quite simply, I think here in Australia, New Zealand, and with the ANZICS registry, we could probably get those definitions in and get agreement and find that we would collect that data in our respective hospitals. But then I think we need more than a minimum data set. I think we need a big data set. But it's no use doing this until we actually get a standardised event form. We all need to be collecting the same data. We can think about then the other pre-met metrics apart from vital signs that we would want to collect, and this might partly be based on any research that comes out of our region in the world to see if it's similar issues in terms of the 24-hour sort of less than 24 hours from ED, etc. I think the clinical deterioration metrics that I mentioned that are certainly appearing in the literature, you can see there's quite diversity in those variables at the moment, but we should watch this space, and this is an area that we may want to progress to measure our outcomes. And then finally, I just want to mention there are many process measures to assess how well the system is performing, and these process measures and many of these we will look at it in our respective hospitals, but we may ultimately want to incorporate these as such a database developed. Such process measures might be the number of family activated MET calls. There's certainly a big interest in that area. I've mentioned ICU admissions is really a process as well as an outcome. I think for hospitals who don't have ICU, they might want to focus on those transfers out of their hospital for unexpected deterioration. Time and day of call, response time in the MET, documentation of vital signs, communication of our escalation of care, time to medical review, staff or family satisfaction. These are just some of the process measures that we probably regularly look at and should definitely look at in our own hospital to see the areas that we need to improve on. Many thanks.